I believe I already mentioned some of the issues with pulmonary effects for chemotherapy and treatment. Sometimes those conditions can be progressive and irreversible. Sometimes patients will develop pneumonitis or pulmonary edema, as I mentioned. Typical treatments are some of the same things that we've talked about before for respiratory patients, like bronchodilators, expectorants, cough medicine, bed rest, oxygen, depending on their oxygenation level. But you could expect some of those type treatments sometimes. Cardiac effects. Patients who have pre-existing coronary artery disease are very vulnerable to developing heart problems. Radiation can actually induce heart disease. You see that a lot of times with patients that have breast cancer that have to, or lung cancer that have to have radiation to the chest. They may actually decide to go other treatment methods to avoid having to get radiation to the heart area, because even though they're pretty precise, you can still have some problems where heart disease and stenosis occurs from the radiation. And a drug called doxorubicin, which in the cancer world we call the red devil. It is a red, almost the color of blood, medication that is given through your IV. So if you're ever on a cancer unit and you see that, you'll know that's what it is, but it is highly toxic to the heart, and most of the time they will make you have an echocardiogram prior to getting the test done, just to see pre-getting that and post if you develop some problems after the fact. And sometimes those effects may take years to develop. And then Herceptin is also another drug that's cardiotoxic. I already mentioned about reproductive effects. So again, planning related to this and counseling is really, really important. Trying to make sure that you do be aware of what those limitations might be post-treatment so that you make plans in advance. In terms of anxiety and depression, it's always important to talk with the patients about what to expect to kind of decrease their anxiety, as we've talked about with patient teaching last semester. A whole lot of times it's fear of the unknown that creates anxiety. Encouraging the patient to discuss any fears that they have, and try to reassure the patient that some of these things that they're going to experience are very severe but are often going to be temporary. And find out what the person's support system is like, and provide them information on services and things that are provided through cancer services. Many communities have a very active program for that, where they can call up the American Cancer Society and find out, help with how to, even things like how to apply makeup without your eyebrows, and how to pick out a wig, or how to pick out a prosthetic of some sort. Just different things that are very unique to the person's cancer situation. And then getting them involved in support groups of people who, both the patient as well as their loved ones, is very important to their psychosocial health and coping through this disease process. This deals with the infection process of cancer. Primary cause of death in cancer patients is infection. They are very highly prone to this because of the treatment and because of just the body as it is breaking down. And then they also have high risk for infection because they have lots of things like central lines and areas that can send bacteria directly to their heart and lungs, and all into causing them to be septic. So the lungs are a big source of infection. The GI tract can be a source of infection. their mouth and their rectum is very susceptible to this as well. They can get germs in their peritoneal cavity through the bloodstream, and it just sit there and grow germs. Sometimes they'll have infections because of ulcerations that can be on their skin or in their mouth. Sometimes infections can kind of be created in a compressed area of the vital organs by the tumor. And then neutropenia can be caused by the disease or the treatment itself, depending on the type of cancer that you have. Cancer pain is a huge area for providing care. The patient should always be believed and be accepted as the primary source for pain assessment. As we've talked about, sometimes multimodal type effects or types of meds should be considered for use in controlling pain. Many of these patients will be on multiple types of both short and long acting drugs, and the further they get into their cancer pain, the worse it may get at end of life and end stage. Sometimes it may not hardly be controllable because it's so bad. But there are numerous things that can be given. And then there are a lot of non-pharmacological interventions, including relaxation therapy, guided imagery, just different things that people can utilize to try to distract them from dealing with the pains. And they really need to take opioids on a regular basis, some long-acting ones, and then have some short-acting ones in between to kind of give them control of their pain a little bit more. There are a few additional hematological cancers like lymphoma and multiple myeloma that you may see people talk about. Some of the ways that we evaluate for cancers of all types is with doing a bone marrow biopsy. This is an invasive procedure, and they literally take with this needle to do a biopsy or an aspirate, and they twist it. They make an insertion, and then they twist it down into the bone marrow. So you can imagine that is not a pretty sight. It's very painful. So they typically need to be pre-medicated with sedatives or some type of pain medications before this is done. And then you always want to get an invasive procedure consent for a bone marrow. And always remember to get your consent first and then pre-medicate, so you're not affecting their ability to make informed consent. Lymphoma is a cancer that affects the lymphocytes, and I think that's covered a little bit in our hematology lecture. The one thing that's different on this slide, I know we're going to mention Hodgkin's and non-Hodgkin's lymphoma, but they look for what's called the Reed-Sternberg cells, and if those are located on a smear that they do of blood, then that is considered Hodgkin's. If that's not there, and they still have lymphoma or cancer of the lymphocytes, then it would be non-Hodgkin's lymphoma. And so this is kind of a picture of what Reed-Sternberg cells look like under the microscope. You can also have what's called multiple myeloma, and it is malignancy of the plasma cells. And we'll learn more a little bit about that. But the key thing about it is infiltration of this occurs in the bones and the soft tissues. And there's a couple different tests there to see that kind of tell you whether you actually have multiple myeloma. But as you can imagine, these neoplastic cells don't get into the bloodstream, but they live in the bone marrow itself. So that's another reason why that one's important to do bone marrow aspirate from. But you can see from this picture, kind of once those cells invade the large bones, it really destroys them on the inside. So you can imagine these folks have serious abnormalities in terms of the way they maneuver, weaknesses, and bones that become completely brittle and break and are non-functional and can be extremely painful. Here's just some other pictures and examples of head and neck cancers. And you wouldn't think that you would see this all that often, but you do when you work in oncology. And you can kind of see where the gentleman on the right there has been getting radiation to the neck, and you see how the redness is from the radiation burns that come from the treatment itself and how the skin can be affected. Other patients may have GI cancers. Can be, in the stomach itself, can be in different parts of the intestines. Colon cancer is a very frequent one sometimes that patients have, and I think Ms. Cade is going to give you some really good examples about that. But you can kind of see how this person has got an ostomy there that is kind of went around wherever a cancer was and kind of rerouted to where his stool comes out in a bag instead of out of his rectum now because of that cancer. So here's a picture of someone that had double mastectomies on the left, and then they got reconstructive surgery, and so you can see that some people can go back to some reasonable looking, or a semblance of a decent look. So it's important to be able to educate patients about that. And then other types of lung cancers, other types of cancers, and considering lung cancer is a very prominent one in our area and region. And we've talked a little bit about that already in our when we talked about cover the lungs before, so I won't reiterate that. Just know that there are also genitourinary cancers of all different types. You'll see people wearing different colored ribbons for different types of cancers, and sometimes they have those on their cars. If you want to support a specific type of cancer, find out what that colored ribbon is and be supportive. Many urinary cancers, prostate cancers in men can be problematic, and in females one of the worst things is ovarian cancer, because no one ever really kind of senses that they have a problem with it until it's huge, and sometimes patients will really have tumors that are the size of a softball that have been in there for a long time, and it's almost where there's not much they can do about it because it's stage 3 or 4, and it's just because the nature of where it is on women, sometimes it's just not, you can get a pap smear but it doesn't show up there. So it's just different things about different cancers to kind of be attuned to. With men with prostate cancer, it can really interfere with the flow of your urine. So one of the things men experience a lot of times is painful urination or difficulty being able to start their flow of urine. And so they do recommend that patients with prostate cancer get regular screenings after as they get into their older adult stages for men, and get that frequently checked on. So hopefully it's been helpful, and this will give you a little precursor to listen to prior to having Ms. Cade come and talk with us on Tuesday.